Hello and welcome to the CSF Rheumatology Author Interview Podcast. My name is Professor Peter Nash from the Griffith University in beautiful downtown Brisbane. We're very fortunate today to be joined by Dr. Stanley Cohen from the Southwestern Medical School in Dallas. Stanley, thank you so much. We appreciate how busy this time is for you with EULAR and presentations and everything else going on. So we greatly appreciate your time. Today we're going to discuss a phase 2 study recently published that's looking at a BTK inhibitor, Fenebrutinib. And I wonder if you just say hi, Stanley, and what your background is a little and what your interests are and what you've been doing.
Sure. Good to be here, Peter. Thank you for having me. I'm a rheumatologist in Dallas, Texas. I've only been doing this now for 42 years. And I've been a clinical trialist for many years, as you have been as well, and been involved in pretty much the development of all the new therapies we have for inflammatory arthritis over the last 30 years. So appreciate the opportunity to talk about this particular study that we were involved in.
Excellent. And we've had some experience with the BTK inhibitor, the Lilly drug, which was a little different to Fenebrutinib. Can you just give us a touch on the background of Fenebrutinib itself and inhibiting BTK?
Yeah, so, BTK is certainly a very attractive target in our diseases because the stimulation of B cells through the B cell receptor and also the FC receptor in myeloid cells uses BTK, one of the intracellular tyrosine kinases, to facilitate signal transduction from the cell surface to the nucleus for the various homeostatic mechanisms and activation of B cells and monocytes and macrophages. So, in sense, we thought it would be an excellent target to go after. This is a highly specific BTK inhibitor, very little off-target kinase inhibition. It's reversible inhibition. Some are irreversible, some are reversible. This is reversible. It's non-covalent binding. So in speaking to the basic folks, I can't really get a good answer why one might be better than the other. But this does differ from some of the other molecules. And to my knowledge so far is really the only BTK inhibitor in a phase 2 study that's had a positive study in our diseases. And whether that's intrinsic to the molecule or wonderful luck remains to be seen. In data that hasn't been published, the long-term extension protocol, that data is coming to fruition now. And it looks like the majority of the patients stayed on drug and did well. So that's to me a pretty positive finding. But the molecule does differ from other molecules, and maybe there is something unique here. The doses picked were based on PD studies, pharmacodynamic studies, and PK studies in healthy volunteers, and had at least a 70% inhibitory capacity of BTK in those healthy volunteers. So I think the right dose was used. It doesn't seem like a higher dose would be more effective. And so again, there may be something unique to this molecule.
Yeah, and because as you said, that it was the covalent binding irreversible drug that we were involved with, it didn't seem to stack up very well. Is this liver metabolized, renally excreted as an oral small molecule? Do you recall just how it's gotten rid of?
I don't actually recall, Peter. I'd have to look that up.
No worries at all.
I don't recall that there was really any significant prohibition if, for renal disease. Certainly if you have significant liver disease, you couldn't participate in the study.
Sure. And I thought it was a very clever design to have two cohorts, the MTXIR and the TNFIR in the same study with an active comparator. Do you want to tell us a bit about how you set that study up?
Right. So, clearly we're looking, this was really more of a hypothesis generating study. So it was powered to do that. And we looked at the typical methotrexate incomplete responders and did the typical phase 2 dose ranging study, looking at 50 milligrams, 150 milligrams once daily, and the 200 milligrams twice daily, compared to adalimumab. And adalimumab was an active comparator, and the study was powered to look at a difference in ACR50 response, which I actually suggested not to be done when this study was being designed, but they went ahead and did it anyway. And then the second study was just a typical smaller study looking at TNFIR patients, predominantly a single TNF agent, but compared to placebo in patients with active rheumatoid arthritis. And basically, what they demonstrated was for the 2 higher doses, as expected, based on the PK/PD, 2 higher doses, the BTK inhibitor, Fenebrutinib, were superior to placebo in the methotrexate incomplete responder patients. And the higher dose, 200 milligrams BID, was superior to placebo, and the primary endpoint being the ACR 50 response at week 12. And so, again, both achieved statistical difference. Now, compared to adalimumab, it did not achieve statistical difference. It was comparable, which was very interesting to me, and I thought exciting. Others were less excited because you're looking at a new therapy, and yet you couldn't beat one of our time-honored therapies. But that, to me, is really not the question. I think we have 15 therapies now of biologics, targeted synthetic DMARDs available in RA. But we still have patients who cycle through multiple therapies, continue to have active disease. So we're just looking for something else that might work in generally the biologic or TNF-IR population. And this potentially could be one of the things that we could utilize.
And I think, as you say, the comparability is important. Many of the agents know better. So then the safety becomes very important. Can you tell us a little bit about the safety side?
Well, there were no really unusual safety signals compared to our biologic therapies. There were a few scattered serious infections, a couple of pneumonias, pyelonephritis, cellulitis, slight trend in dose. There were a few transaminitis noted, similar to what we've seen with other kinase inhibitors, but very manageable. One case of zoster seen. Small study, limited duration, so it's hard to be really dogmatic about the safety, but there was nothing here that looked to be a deal breaker. Really didn't see anything with lipids, didn't see anything as far as leukopenia, neutropenia that was of a concern. We did look at biomarkers, and there was a reduction in IgG and IgM levels in patients on the higher doses, dose-dependent fashion, modest reduction in rheumatoid factor activity. And I think that's something that will need to be monitored if this molecule moves forward in further studies with more longer duration. What impact will it have on immunoglobulins?
Because you did enrich the patient population for seropositivity, and it was nice to see those markers come down. Can you give us a sneak preview of the open label extension, whether any of them got hypogammaglobulinemia down the road? Or
there were some, again, the data is not in the public domain. I probably talk a little bit. It was not a significant clinical issue.
Okay, and so we can't comment on seronegative patients at this stage, but maybe you look at that later.
Yeah, I think it'll be looked at later. We just, and again, this is, as you well know from the work that you've done, this was proof of concept. Can we see a signal that we can now go to our bosses in pharma and say, we have something we think is worth developing, and we want to move into phase 3.
Excellent. And do you think it will proceed? Do you think you had enough results to move forward? Because 12 weeks is with antibodies that live for 3 months. I would suggest in the next 3 months, you're going to see the best effect of this drug.
Right. Again, it's a slow-acting therapy. We've seen that with rituximab. We've seen that with belimumab. These B-cell inhibitory therapies take longer to work. So the answer is those discussions are ongoing. I can't give you a definitive answer. We really push for them to continue. RA is a crowded field as far as therapies now, but we still need new therapies. We don't need another drug for methotrexate incomplete responders, but we do need medications for patients who fail biologics or targeted synthetic DMARD. So I'm cautiously optimistic.
Okay, and take-home message for the clinician from this study: is it a good target, do you think, and it's going to offer some advantage?
I think it is a good target based on its being found in hematopoietic cells that are involved in the synovium and the inflammatory process. Pleased by the results of the phase 2 study. Somewhat surprised, but pleased. And I do think that it would be a shame not to pursue further investigation in our field in rheumatoid arthritis. And if successful there, you could think of possibly even other diseases that might be useful.
Yeah, you'd think lupus would be a good target. And no imaging in this study, but you weren't tempted to MRI a couple of patients and see what happened to their synovitis?
So Peter, I'm sorry, you broke up a little bit. Can you repeat that question?
Sorry, no imaging in this study. You weren't tempted to MRI a couple of people and see what happened to the synovitis?
I mean, we might have been tempted, but that was Nick from the beginning. But that's certainly something we'll have to be looked at. I'm one of the folks who's on one side of the pendulum. I don't think we need X-ray studies anymore to spend all that money to see a change in a sharp score of 0.4 or 0.2. I do think that a subset study with MRI showing changes in osteitis, bone edema, synovitis would be helpful to make us feel comfortable that it's disease modifying. But, you know, like most sponsors, if the phase 3 study moves forward, there will be an X-ray portion.
Right. So we can see lots of future use for oral small molecule rituximab, if you like, in all kinds of different situations. So we congratulate you on. Yeah. Keep going.
I certainly think that's the case.
Yeah, yeah. So we hope the bean counters don't ditch it because it was comparable and not superior. We'd like to thank you for your time. This has been the CSF Author Interview Podcast. If you'd like to know more about this paper and others uploaded to the CSF website this month, detailed slide sets are available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes or wherever you get your podcast from and let us know what you think. And we thank you very much for your time. Early, short-term phase 2 study. Look forward to what comes next if the bean counters let it go ahead. Thank you very much for your time, Stanley.
Thanks, Peter. Good talking to you.